Hello and welcome, everyone. We're very happy to have you all here tonight. The Review and Debates is proud to present to you the debate resolved that the Affordable Care Act has not failed, or was not a failure. And tonight we have the lead proposition, Dean of NYU Wagner and Professor of Public Service, Glied, right over here. And she will be supported by Deepak, a freshman at the College of Arts and Science. And then leading the opposition is Ella, a senior at the College of Arts and Science. Supported by Sofiya, a senior at the College of Arts and Science. We really went for the diversity of schools here, as you can see. And I am Dino, your moderator tonight. If you have any faults, if you want to throw tomatoes and other vegetables at me, throw them at me, I'm your target today. So, just a PSA, we will be videotaping this debate tonight, so if you have any issues and if you don't want to be in the video, we would ask you to sit back in the last two rows. Okay, and with that, I'll outline the debate. Each speaker will give an 8-minute speech, followed by a Q&A session with the audience. That means you will be asking any and all questions that you have about things that they might have said, or things that you came in with questions already and you want to ask them. You can ask anybody at either bench, and both sides will get a chance to respond. And with that, I will just give a slight introduction to what the Affordable Care Act is, to those of you that might not know. The Affordable Care Act, or commonly known as Obamacare, is a United States federal law enacted by President Barack Obama in 2010. Under the Act, hospitals and primary physicians would transform their practices financially, technologically, clinically to provide lower cost and quote-unquote affordable care. And with there was a legal challenge to the Medicaid expansion that gutted the Act in 2012, and now we have only part of the Act since that time. With that, we'd like to begin the debate. First off, with the opening speech from Dean Glied. Give it up.
Okay, thank you. Right, so I would assert that the Affordable Care Act has not failed. Indeed, I would actually dare to say that it has been a great success. And I think the challenge in this debate is really not with what the law is and not with its implementation, but actually the premise of the question itself. I think it actually reflects a misunderstanding about what law and policymaking are actually all about. Law and policymaking are not football games that have well-defined periods and goalposts, so that after some set amount of time, you can say whether something has been a success or a failure. And they aren't final exams with questions and answers and grades that are posted in Albert. Most pieces of legislation are an amalgam of many objectives. They're idiosyncratically weighted by different lawmakers. This is why the Supreme Court has a hard time figuring out what the intention of Congress is. And the implementation of any piece of legislation plays out over decades, and the outcomes are reassessed frequently in light of later changes, so that people's assessments of laws change in subtle and not so subtle ways over time. That is true of all legislation, and it is particularly true of the Affordable Care Act. The law contains 10 different titles. You used to talk about a few of them. That is sections with different, very broad goals. It is 2,700 pages long, and there are over 20,000 pages of associated regulations. So it is very hard to know how to assess success or failure as a premise to begin with. I'm going to offer two different approaches that both, to me, suggest that the law has been a tremendous success. The law has many, many pieces. That said, when it was first being debated in Congress people had a bunch of questions that were central to the debate. The first one was, what will this law do to the uninsurance rate in the United States? That was probably the #1 motivation for the law, and that was the question on everyone's mind. Second, what will the cost of this thing be, and how will it affect the federal deficit? And third, will a lot of people decide to go uninsured and pay the penalties rather than being covered by the law? So we actually have goalposts and metrics and timetables for these particular objectives, because when the law was passed, the Federal Congressional Budget Office, which has the job of scoring legislation, actually provided estimates for these parameters, and it was based on those estimates that Congress decided to pass the law. Subsequently, the Congress, which is now the Republican Congress, has asked CBO to compare their original estimates and what happened, so we know. And here goes. So you mentioned that the Supreme Court ruled on the constitutionality of the law and changed the goalposts. Right after that, the Congressional Budget Office gave estimates of what the law was going to do by 2016. They predicted that in 2016, 89% of the United States population would hold health insurance in consequence of the law, and 31 million people would remain uninsured. In March 2016, after the most recent open enrollment period ended, the CBO revisited those estimates, and they said 90% of the population has health insurance, and 27 million people remain uninsured. So the law beat the projections. It did better than the people who passed it thought it would when they passed it, and in that respect, it has been a success. In July 2012, the Congressional Budget Office estimated that the net cost of the law would be $127 billion. When they revisited it, the net costs were only $110 billion. In consequence, the law has substantially reduced the federal deficit by much more than it was originally forecast to do. The law actually beat the projections again. If Congress had known then what it knows now, it would have built in bigger subsidies, because it actually spent less money than they thought. A big component of the difference is that premiums originally quoted on the insurance marketplaces were so much below the original estimates. CBO originally projected that exchange subsidies would be about $5,500 per person. They actually came in 20% below the projections as of 2016. So the cost has been much lower. Finally, in 2012, the CBO estimated that by 2016, the federal government would collect $5 billion in penalties for people who chose to remain uninsured. No, millions, sorry. The actual figure came in at 60% of the number. So fewer people have decided to remain uninsured, fewer people are paying penalties, more people are covered, the deficit is smaller, the cost has been lower. So based on the criteria Congress was considering at the time the law was passed, it has been a roaring success. What about other criteria? Well, when the law was passed, a lot of people projected disaster, and they actually went out and said why they thought the law was going to be a disaster. So another way to assess whether the law has been a success or a failure is to see whether the things that people thought were going to happen that were terrible have actually happened. I collected a representative sample of these. I went through the websites of all the various Republican organizations who complained about the law to see what they said. One set of them said the law is going to destroy the labor market, it's going to lead to massive unemployment, part-time work, lower earnings, and so on. None of this has come to pass. Earnings are up at the highest level ever, more people are employed, part-time work has dropped. So on that measure, the law has not been a failure at all. A second set of critics worried about access to care. They said, you're going to expand coverage, but people are not actually going to be able to use it. There are not enough doctors. The hospitals are going to go bankrupt. Insured Americans will be crowded out of the system. None of that has happened either. The vast majority of newly insured people, whether they're in the marketplaces or in Medicaid expansions, are satisfied with their coverage, satisfied or very satisfied with their coverage. They have been able to access care that they couldn't get before. They were able to find new doctors to see them. There has been no discernible negative effect on access to care for those already insured. So that whole idea is totally false. Third set of concerns has been about the effects of the law on the healthcare system itself. The cost of the law was basically borne by hospitals, which received lower payments going forward, and by Medicare Advantage plans, which also received lower payments going forward. So when the law was passed, critics said this is going to cause hospitals to go bust, and it's going to cause the Medicare Advantage program, which is the private program inside the Medicare program, to disappear. That hasn't happened either. Managed care enrollment in Medicare is at an all-time high. Hospital margins are robust. There have been big declines in uncompensated care, especially in the states that chose to expand Medicaid. So on that metric as well, I'm just trying to see, the law has been a success and not a failure. So not only did the law meet the goals of its proponents, it also avoided all of the catastrophic disasters, the parade of horribles that its opponents had put forward at that time. Now, I don't want to sound too Pollyanna-ish and suggest that nothing went wrong. Some things did go wrong. There were fumbles. And in fact, I want to just point out some because, just to be totally honest here, some things didn't work. One of them was, one entire title of the law, the Class Act, the Department of Health and Human Services determined could not be implemented in a way that was actuarially sound. So that's actually a failure of the law. The Independent Payment Advisory Board, which was supposed to lower prices in Medicare, Congress stymied it and stonewalled the appointment of members to it, so it never happened. And the Supreme Court decision in NFIB versus Sebelius means that 19 states don't have a Medicaid program in place for their poor residents, which means that lots of people remain uninsured. And I think that is in some ways a failure of the law too. But against those stumbles, which are not central, I think, to the assessment of the law, I could go down the 2,700 pages and list successes until you all have to go home and go to bed. No more pre-existing condition exclusions, young adults covered on their parents' health plans, closing of the Medicare prescription drug donut hole, reduced hospital readmissions, home-based primary care for the chronically ill, nutrition labeling, chain restaurants, expanded loan repayment programs for healthcare professionals, enhanced checks on fraud and abuse, prescription drug sample transparency, more competition in the biologics drug market. I could go on. So I don't want to argue that the ACA is a perfect piece of legislation or that its implementation went perfectly smoothly. This is the real world. Nothing is perfect. Implementation is never entirely smooth. But even here at NYU, where standards are pretty high, I think that the ACA and its implementation will get an A.
We'll now be hearing from Ella to give the opening opposition speech.
Thank you. My friend and I here are pleased to sit before you and sit in opposition to the resolution that the Affordable Care Act has not failed. I begin by saying that if a man is hungry and chooses to eat pizza to satisfy his hunger, it would not be uncontroversial to judge the success of his decision to eat pizza based off of its ability to satisfy his hunger. Similarly, if the president sees soaring healthcare costs for both individuals and for our country and chooses to implement the Affordable Care Act, it would likewise be uncontroversial to judge the success of the Affordable Care Act based off of its ability to decrease healthcare costs. To be more precise, we will uncontroversially define the ACA's goals as stated by the ObamacareFacts.com, as to give more Americans access to affordable quality health insurance and to reduce the growth in U.S. healthcare spending. The burden for the proposition then should be to show that the Affordable Care Act provides affordable quality health insurance and reduces the growth in U.S. healthcare spending. The opposition will argue that not only has the ACA failed to provide affordable and quality health insurance, but because the foundation of the ACA was built upon the Medicaid system, it will always necessarily fail. Before diving into soaring premiums and the status quo, we find it important to journey back into the year 1942. The Stabilization Act of 1942 amended the Emergency Price Control Act of 1942 and was designed to stabilize wages, excluding insurance and pension benefits. Companies took advantage of these exclusions and began offering health insurance as a way to retain or attract new employees. Beginning in 1943, Tom Miller for the National Review writes, the Internal Revenue Service worked to codify this phenomenon with the Internal Revenue Code of 1954. This code, he writes, permanently established in federal law generous tax advantages for employer-paid health insurance premiums. Those group health benefits are excluded from employees' taxable wages and therefore not subject to income and payroll taxes, unquote. These tax policies incentivize employers and unions to sponsor group health insurance plans. Unfortunately, similar to the bundling of transaction costs in financial institutions, which many of you know will be unbundled with MiFID II in Europe in 2017, Miller writes, quote, the tax exclusion also created unintended problems for the structure, cost, and availability of both private health insurance and healthcare, and these problems continue today. It has been criticized for raising and hiding the overall costs of health insurance and healthcare. Today, Joseph Antos of Forbes writes, about 57% of the under 65 population are covered by employment-based health insurance. So while the proposition has argued that the coverage rate is about 90% of the population, I would argue that's unsurprising given that 57% of the population is covered by employers. The Obamacare Act was designed to cover the people who were not able to get coverage before, but it failed to deal with the problem of employer-based insurance. To be more precise, the reason why this unbundling is problematic is because it actually obscures the actual cost of healthcare. As a result, Sally Pipes, the president of the Pacific Research Institute, writes, insurers have remained on the exchanges or pushing for double rate premium hikes. While United Health wants to raise premiums for its exchanges in New York to 45.6% because insurers have lost so much money on the exchanges thus far, state regulators are likely to grant these rate hikes. If they don't, even these insurers may leave. To address the employer-based model of insurance, the ACA introduced the so-called Cadillac Reform, which levies a 40% excise tax on the cost of employment-based health benefits that exceeds a certain threshold. Unfortunately, though it will not be implemented until 2020, Santos explains that the Cadillac tax will eventually hit virtually all Americans and will be problematic because it's indexed for general inflation rather than the more rapidly rising cost of healthcare, which we argue is very problematic. In addition, the Cadillac tax does not address the heart of tax exclusion, which, quote, has caused a shift in compensation from taxable cash wages to greater health benefits, which are not taxed, as evidenced by the fact that between 1999 and 2015, the average employer contribution for family coverage nearly tripled, while wages increased by only about half. A successful Affordable Care Act then would make the price of health insurance more transparent and actually grapple with the structure of employment-based insurance. The other thing that the Affordable Care Act is set to do is to tackle these pre-existing conditions. But when you actually look at what a pre-existing condition is, if you are not insured by an insurance company and then you get sick and then you try to apply for insurance, that's considered a pre-existing condition regardless of the severity of your actual health. The other problem is that the writers of the Obamacare Act did not actually look at the pre-existing conditions at the time because Paul and Herring, as commissioned by the U.S. Department of Health and Human Services, found little, if any, evidence that enrollees in poor health generally paid higher premiums for individual insurance. This is because they were protected by the employer-based insurance in the first place. They also found that 35 states already operated high-risk pools with collective current enrollment of 222,000 individuals to ensure access to coverage for individuals with pre-existing conditions. That number is actually higher than the estimated 134,708 individuals who enrolled in the Obamacare plan to cover individuals with pre-existing conditions. So what we see here, which is a bit problematic, is the Obamacare Act was basically designed to cover the people with pre-existing conditions, but it failed to recognize that states were already taking care of these pre-existing conditions with their own plans. It failed to grapple with the employment-based insurance that covers 57% of people today, and it failed to tackle the high-risk pools that were already happening. In addition, and this is a minor point but still important, I think, it also provided a lower quality of care. Today, physicians increase the number of patients they see, resulting in an average face-to-face clinic visit of 12 minutes. Unfortunately, the Affordable Care Act has codified this broken system into law. The problem here, while seems minor, basically means that when you go to see a doctor, you don't have a physician, you have a hostage. This not only decreases the quality of care, but it makes doctors able to be pushed over by patients. They're not prescribing exactly the right quality of medication that they should be, and they're able to sort of get swindled into providing a different kind of service than they initially intended to. To address, I suppose, the proposition's points about policies are sort of difficult to measure given, that they unroll over time, I would say that although that's true, I think taxpayers, we as taxpayers probably deserve to understand the system beforehand. And regardless of what cherry-picked examples they'll throw at you and show, well, it worked in this state or it didn't work in this state, the point is the very structure of the system was built on Medicaid, and it didn't actually tackle the core of the issues that we outlined for you. So because it didn't deal with sort of the root of the issue, we would argue that it can never succeed, regardless of what examples they provide of where it has sort of succeeded.
We will now be hearing from Deepak. And Deepak, it's not too much. I would ask you to use the podium.
Okay. Okay, thank you, Dino, and hello, everyone. Before I move on to extending what Dean Glied has told us, I would like to respond to what opposition has raised. The first thing that they raised was the issue of how the ACA in general has been disappointing. They gave us a lot of detailed analysis about why it has been disappointing, but we would like to step back a little bit. We'd like to point out that what the ACA did was that it plugged the vital gap between Medicaid and employer-provided insurance. The ACA benefited, 10 to 15 million Americans who gained access to healthcare. And in doing so, the ACA harvested the low-hanging fruit of healthcare reform in America. These are people for whom a sudden pain in the abdomen, a fracture of the wrist, means having to make the stark and terrifying choice between financial ruin on one hand and sudden, possibly permanent disability on the other. Bodily ruin versus busting a bank account. And it's perplexing that in one of the wealthiest nations in the world, well into the 21st century, that painful and inhumane predicament could still exist. So in this context, the Affordable Care Act was an unprecedented step, an unprecedented success in getting somewhere, in doing something in the first place. Now what's more, the last significant reform to healthcare in America was Medicare and Medicaid in 1965. In the 5 decades since the passage of Medicare and Medicaid, the Obama administration was the first to liberate these 10 million Americans from their predicament, and that number looks set to increase. If side opposition still remains disappointed with Obamacare, we tell you that the ability of the Affordable Care Act to succeed was limited by political dysfunction. We can argue whether or not various particulars of the ACA were desirable, but the reality is that the political climate in which they took place, in which they were passed, made further reform unrealistic. Tellingly, Obamacare has had the most success in states that assented to the expansion of Medicaid, including, for instance, Montana, which experienced a precipitate reduction in its uninsured rate after expanding its Medicaid program just this year. Same thing has happened in Kentucky and Arkansas. Uninsured rate fell by up to 75%, outstripping the national average. Compare this with Texas, for instance, which did not accept Medicaid expansion. No such improvement seen. Once again, I echo Dean Glied in saying that I could go on extolling the benefits of Obamacare, but suffice to say that Obamacare isn't just better than nothing. It was implemented, in the conditions under which it was implemented, it represented a significant success in surmounting the political and legislative hurdles it faced. Second thing they told us was that they tried to identify several problems with the cost and quality of care. Now we have to note first and foremost that this is better than the alternative. The benefits of higher premiums, slightly reduced coverage, slightly reduced quality of care still outweigh the immensely costly risk to the 10 to 15 million Americans that we're talking about of having your body and bank account busted at the same time. Now even if that continues to be a problem, even if cost and quality of care continue to be suspect, these problems are not catastrophic. As Dean Glied said, the room for increased subsidies mean that the cost of care is lower than the sticker price that we see. 85% of sign-ups in the first enrollment period receive subsidies of up to 75%, and they can go up more. There is fiscal room for them to go up more. Neither are these problems insurmountable. Neither are any of these problems insurmountable, and here lies the genius of the Affordable Care Act. It's constructed not as a lump of policy, but as a complex organism that can continue to change in the years, decades, even centuries ahead. So some instances, the shared responsibility payment penalty for not signing up for insurance needs to be adjusted upwards so that premiums can be lowered because there are improved loss ratios for the insurance companies. This is a very straightforward change that can solve many of the problems that the ACA faces, some of which side opposition pointed out. Many Democrats have also moved to the idea of a public option, a government-run insurance plan to compete with these privately run insurance plans. Compete with, perhaps substitute, or even complement, as the case needs to be, depending on the situation, depending on the outcomes of the status quo. Another option is the narrow network strategy. Limiting coverage allows insurance companies, limiting the doctors and the medical care providers that a given insuree can go to, gives insurance companies more monopsony power to negotiate down prices with healthcare providers. And here lies one enormous solution to the problem pointed out in the bulk of the first opposition speaker's speech, which was that insurance is simply very expensive because healthcare costs are very high. The point is that none of the problems with the Affordable Care Act are immensely insurmountable. And the third big problem that they pointed out was about the future of the Affordable Care Act, about the whole idea of it being dependent on Medicaid. That I will deal with when I move on, as I'm doing now, to my substantive case for today, which is trying to step back a little from what Dean Glied has said and thinking of the ACA in terms of the Obama administration's legacy. The ACA was implemented in a healthcare system that was deeply troubled. The only time, as I said, the only time we had attempted to make it work was back in 1965. So you have to look at the Affordable Care Act along that time horizon. What the ACA has done is to set the stage for healthcare reform in the next 50 years. Its universal personal mandate is an unprecedented step forward. Seen from this perspective, accusations that Obamacare has failed are largely premature. But even while we allow it in its first few years to establish a foothold on the mountain that is healthcare reform in America, we see that at its core, the ACA is inherently designed to be able to succeed in the long term. It is sustainable. So we see sustainability built into the system in the form of, for instance, the risk corridor, which is a mechanism for sustainability because it pulls the risk for insurance companies. It collects money from highly profitable insurance companies to give to loss-making ones. Pulling that risk keeps them in the market in the long run, keeps competition up, keeps premiums down for healthcare consumers. So at the same time, consumer interests are balanced against the profit sustainability motive. The ACA mandates a minimum loss ratio for the insurance companies of 80 to 85%. Anything more, and consumers actually receive rebates on the premiums that they have paid. $470 million was paid out as rebates in 2015 alone. Finally, and this is where I deal with the problem about the future of Medicaid that side opposition brought up. We're seeing the growth of an economy, as they correctly pointed out, where fewer people will have employer insurance. More people are going to be driving Ubers, operating Airbnbs. If this means that a traditional reliance on employer-provided insurance will become outmoded and irrelevant, then the ACA preempts that problem. It's already poised to plug that crucial gap. Without the ACA, the problems that they identified would be all the more problematic for us. So the ACA is not perfect. It's obviously the early days and there is work to be done. With any luck after the election next week, Obamacare will continue to succeed. Successive administrations will continue to build on it, to improve on it. In 50, 100 years from now, our children and grandchildren will look to the ACA as a pivotal moment in the history of American healthcare. They will remember the intense and bitter opposition to the nitty-gritty details of the ACA from its detractors today, and they will call these detractors reactionaries, consumed by the petty politics and the ideological spats of the day. Obamacare has not failed, it has succeeded, even in this context, even in the short span of time it has existed, and it will continue to succeed in the very long run. Thank you.
Okay. And now we will hear from just a question. Could you hear the knock? Okay, good. Okay. Sorry. So now we will hear from Sofiya, who will give the supporting opposition speech.
Hello, everyone. First, I'd like to request that the other team describes what they define as affordable. Because the reality is that Obamacare is anything but affordable for a majority of Americans. In the most recent Gallup poll collected in September on the ACA, 29% of Americans say that Obamacare has significantly hurt them, while only 18% report that it has helped their families at all. This framing is critical because it reinforces the notion that Obamacare is hurting more individuals than it is actually helping. Largely because it is unaffordable, but also in part because it does nothing to address the concerns of quality of care disparities and also increasing cost of care. A critical distinction that must be drawn in this debate is that access to health insurance does not mean, in of itself, access to health care. As my partner mentioned, simply ensuring a larger percentage of the population has not been associated with realized improvements in access to quality of care or any improvements in the remarkably high cost of care. There are larger structural issues that the ACA has not and will not be able to tackle because of its absence of teeth to actually have any enforcement mechanism. Specifically, the average standard silver plan, that is the most common plan available in the marketplace, covers only 70% of negotiated hospital doctor fees, and it has a high deductible of over 6,000% on average. This means that individuals have to pay as much as $6,000 out of pocket annually. A key reason for rising premium costs is that competition in the insurance marketplace is steadily declining. In 2016, at least 5 states will only have a single choice in the marketplace. This means that all of the insurance companies are pulling out because they can't spread their risk wide enough. It means that young people are not enrolling in Obamacare at the anticipated rates, which is causing a lot of insurance companies to pull out because they can't actually cover the areas and still make any money. They're losing money based off of Obamacare. This is correlated with high rising premiums that a lot of people are saying are making them decide whether or not they actually want to have Obamacare. This year, premiums will rise as much as 20%. Obamacare has also resulted in numerous mergers and consolidations between healthcare providers. They say that hospitals have the burden. However, hospitals have the burden so far and so much that they can't actually exist anymore, so they're merging, and this is increasing costs as much as 20%. Also, Medicaid was a flawed foundation. They haven't addressed this. Dr. Robert Betts, a professor of Georgetown University in public policy and founder of the Robert Betts Associates, a healthcare policy consulting firm, uses Pimp My Ride as a great analogy of what Obamacare is. In the hit MTV show, rapper Exhibit would surprise poor individuals who have old, broken-down cars who can't afford new ones, and they would make over their car. They would put in Corinthian leather, hydraulics, a new Bose sound system, but really, it was still the same car. It was still the same foundational framework that you were making all of these improvements. And that system, that car, would still ultimately fail shortly. We still have a lot of issues with Obamacare. There's no national data on the extent of the issue. This is problematic because there was a provision within Obamacare that said we should have the data collection, but it's not being readily available to the public. Avalier Health determined that in Florida, California, Texas, Georgia, and North Carolina, exchange plans included an average of 34% fewer providers than commercial plans. The constraints in access are further exacerbated by the decline in competition. In the enrollment period that begins today, 5 states, again, will have one marketplace option. This means that people who had other options, according to the marketplace, they have to change their physicians, they won't be able to see the same providers, they won't be able to see probably people in the same network. And this is going to drive up costs because there's no way of anticipating who's going to get care and who's going to utilize it. The ACA's primary target groups, as they said, were low-earning Americans who made too much to qualify for Medicaid, but not enough to afford commercial insurance. Those who could not acquire insurance through an employer, either because they were self-employed or because small businesses did not offer enough coverage. For both of those groups, Obamacare has failed. There are significant differences in the plans that the ACA provides as compared to those provided by employers. The policy journal Health Affairs has reported that out-of-pocket costs, prescription costs, were twice as high in the Silver Plan as compared to the average employer option. Most significantly, Dr. Polsky conducted research with the Robert Wood Johnson Foundation and found that 41% of Silver plans provided a narrow or very narrow choice of doctors, which means that at best, only 25% of physicians were available to patients on the Silver Plan. In regards to specialists, the consulting firm Avalier Health, again, reported that exchange plans had 42% fewer cancer and cardiologist specialists as compared to employer-provided plans. Also, Obamacare has not realized the promise of keeping children on their parents' plan until the age of 26. This is largely because there are in-state constraints. So when we, as students, go out of state to college, this means that we can't actually have insurance that's provided by our parents' insurance plans unless they also live in New York. So this means that a lot of young adults are left uninsured or have poor insurance access or realize poor access to care because they can't actually enforce a lot of the provisions of Obamacare. Also, Obamacare does nothing about cost of care. Cost of medical care is, one, closely tied to geography. The critical example is that the cost of treating a heart attack in LA is at least 3 times more expensive than it is to treat a heart attack in Omaha, Nebraska. So, as of right now, we have 20 million Americans enrolled in the marketplace, Medicaid expansion, and young adults on their parents' plans. However, uninsured Americans are still at 11.9% for 18 to 64 in the age region, and 8.6% for all Americans. Yes, uninsured rates have gone down, but this does not mean that access to care has actually improved, because if you look at a lot of recent findings by the Kaiser Family Foundation, only 60% of those who purchased a marketplace plan actually used it. Of those people, of those 60%, only 62% said that they could not have previously afforded this care. In short, the 60 and then 62 means that you have under 3 million people who are reporting any sort of tangible benefit from Obamacare. This 3 million people is not to be understated, because it means that the rest of the population is bearing the tax burden, is bearing the rising cost of premiums all around, is bearing the lack of alternative options through commercial insurance plans. And a 2015 study by Health Affairs conservatively estimated that insurance coverage in 2015 was only 2.6 better than pre-recession baselines. Additionally, they haven't answered the concern of growing health expenditure. In 2014, the national health expenditure rose by 5.8%, the fastest rate of increase since 2008. According to the CDC report on financial burden of healthcare costs in the US, among families in which all members had public coverage or private insurance, 21% experienced financial burden of medical care in 2014. That's time?
You have 20 seconds.
Oh, okay. And a lot of people are still rationing care. Since the implementation of Obamacare, 50% of Americans are still reporting financial burden to filling prescription costs or seeing physicians. In short, Obamacare did not address any root cause issues. It only made them worse.
Okay, thank you to all the debaters. Now it comes time to hear all of your voices. That means you get to ask any questions that you might have about what you heard tonight, or anything that you thought of coming into the debate. So, who wants to start off? Any questions? Yes.
Yeah, I just want to ask about the Supreme Court decision, and they basically sided with Obamacare, and I want to know what you.
So there have been actually 3 Supreme Court decisions, but let me just talk about the first one, because that seems like an important one. When the law was passed, almost immediately afterwards, 2 sets of lawsuits were brought against it. One was an argument that said that the individual mandate, which is part of the law, was unconstitutional. Second part of it said that the Medicaid expansion, which was part of the law, was unconstitutional. The first one was it was unconstitutional as a violation of the Commerce Clause, but the second one was that it was unconstitutional because it consisted of the federal government forcing states to do something, which the federal government is not allowed to do. What the law had said is that if a state did not expand its Medicaid program, all of the federal government's money going to the Medicaid program would be withdrawn. The Supreme Court determined that the individual mandate was constitutional. That had been the big question, and that's actually the question everyone was focused on. But they decided that taking away the state's entire Medicaid budget for not expanding Medicaid was too draconian a penalty, and the federal government could not do that. And in consequence of that, some states chose not to expand their Medicaid programs. In the coconut shell.
Do you have a
Yeah, so I think that there's a lot of it is also gut check, that a lot of what the Supreme Court decided was that we couldn't leave 3.6 million Americans uninsured, which meant that even if states had decreased access or expansion of Medicaid, right now the number stands at 19 states did not actually expand Medicaid. So a lot of the core provision of Obamacare still has resulted in realized uninsured populations across the United States.
Okay, yeah, next question.
Sorry, kind of elaborating on the Supreme Court decision. So was it just like the severity of the punishment?
Yeah.
Oh, okay. Because I was like, the federal government does that all the time.
Yeah,
with,
no,
like,
the argument was that
laws
this is
and-
too big and this is too much money. So, now I should say that in every year, more and more states have chosen to participate in the expansion. So it looks like over time, the trend is moving in that direction.
We went from 22 to 19 uninsured. Yeah, so only 3 states have actually changed their decision.
No, not since 2014, not since the very beginning. Indiana joined, and Oklahoma joined, and Louisiana joined, and Montana joined, and so there's been.
From 2014, from the last Supreme Court decision until now.
Okay, next question. Any other questions? Yes.
I have a question for the opposition. So you've gestured towards some statistics indications that Obamacare perhaps has not worked for everyone, but could this be attributed in fact to insufficient implementation of the program rather than structural failure?
Strategic implementation, as in, do you mean that it doesn't have, so one, there is the argument that the tax penalty was never high enough to get people to actually pay the premiums, right? So right now it's at about $700, but in years before it was around $300. So a lot of people were choosing to not pay that. But the other side is that commercial plans were still seen as much better. That a lot of people who were on employer-based insurances chose to remain on them rather than move to the Obamacare.
I would say it's still, I would still say it's a structural problem because like if it set out to help the people with pre-existing conditions, right, which like they estimated to be 15 to 20 million, then later realized it was actually only like a few 100,000 people that actually couldn't get insurance. If they're really trying to only help this population, it seems like the structure of having the entire nation like sign on to create like a healthy pool to outweigh the risky pool, like that whole structure to me just seems like systematically flawed.
But why do you think that the only reason they wanted to do it is to cover the people with pre-existing conditions?
I don't think that's the only reason, but I think
Or even the main reason? That wasn't the main reason.
Well, I think a major factor is to make sure that everyone is insured. And when it comes to why people wouldn't be insured beforehand, it's either they couldn't get insured or it was not affordable to them. So they sort of use the benefit of insuring the entire population to offset sort of the high costs or the inability to get care of some populations to help every population sort of get access. And I don't think that it ultimately achieved that because as of now, a lot of people that are in the lower class are actually opting to pay the fee and not get insurance than to pay the premium and to get insurance. So I think to me that's indicative of a failed system.
Next question. Yes.
I'm sorry. I have a question for the opposition in the negative. So you talked a lot about how like structurally that Obamacare was based off a bad model, Medicaid, but I'm a little confused. Why is Medicaid and Medicare like such a bad model, or why is that always structurally going to fail? I don't really understand.
So Medicare is a monopsony, right? So in Medicare, which is for individuals over the age of 65 or those, I believe, with ALS or another condition. But so Medicare is a single buyer. So the federal government has to negotiate individually with other, with hospitals, with doctors. So that means that they can negotiate just one model for all. However, the Medicaid targets the poorest of the country, so a certain percentage below the poverty line as determined by the individual states. So Medicaid, unlike Medicare, which is federally established, is up to the states. So states have the ultimate decision on what options they want to include, what they want to not include as services, so like dental, a lot of other certain provisions aren't covered under Medicaid. And the other problem is that Medicaid reimbursement rates are incredibly low as compared to Medicare and commercial insurances. This means that when reimbursement levels are very low, a lot of doctors don't take patients. As high as 67% will not take patients at all. So that includes either new Medicaid patients or patients, Medicaid patients or Medicaid patients at all. So a lot of doctors, same problem with Obamacare, that as much as 34% of providers aren't even seeing patients on the plans.
Does the proposition have anything to add?
Well, I think the opposition is, takes two opposite positions. One is that we need to have a monopsony so that we can lower the prices and keep the cost down. And the other one is that the problem with, so one set is, sometimes they argue that the problem with Obamacare is we don't have a monopsony so we don't keep the prices down. And then sometimes they argue that the problem with Obamacare is we don't have enough competition. It can't be both of those things. So it's either we should have had a monopsony and just gone to a single payer plan, or you could argue that, I don't know, you wanted more competition. But somehow you can't be arguing both of those things at the same time, which I think is sort of the fundamental issue here. But as to Medicaid, it's not actually clear that within Obamacare, if people had wanted to choose the broader network plans, they could have chosen them. They didn't. Most people who are, because of actually the point that they made, which is that most people buy health insurance for the same reason that they buy home insurance or life insurance. They're not expecting to die or for their homes to burn down. They just want to make sure they're protected in case that happens. So the fact that people don't use their home insurance, we do not think of as a failure of home insurance. The same thing is true in the case of Obamacare. Many people don't need to use services. They still need health insurance in case something happens to them and they do need services. As those people entered the market, they were perfectly willing to choose narrow network plans that had relatively lower access for a lower price. I don't see why we should think that those decisions are wrong.
I mean, arguably though, like the chance that your house burns down is probably a lot slimmer than like you getting a cough and needing to go and get like cough syrup from your doctor. In my opinion, I don't know.
But then the question is, why should that be covered by insurance at all, right? So ordinary everyday things we don't usually think of covering by insurance. So, and in fact, under Obamacare, we don't cover them very much by insurance because deductibles are high enough that you pay for those things out of pocket. Which is a reasonable strategy, just like everything else isn't covered by insurance.
What about like dental checkups or other things that aren't like covered by insurance? I know, you know. that's
Pediatric dental care is covered under Obamacare and adult dental care is not.
Okay, next question. No more questions. You all agree with everything you heard tonight. Yes.
Are there any guarantees in place that, well, to both, guarantees in place that the insurance offered on the market will be accepted by the majority of providers?
Insurance plans participating in the exchanges have to guarantee that they have an acceptable network of providers. So there are actually minimum standards on the number of providers who have to be in the plans in order for them to be offered.
What is acceptable is determined by the states, so there is no, I mean, there's a lot of disagreement upon who gets covered and what is covered, so still by providers and how much they will charge for those. So that's why you don't see a lot of realized access to care, even if you do have access to a health insurance.
That's not true. There's been an enormous increase in access to care. In all of the surveys, people report much greater increases in access to care.
Right, but they're still paying $6,000.
They might be paying large deductibles, but actually
so
average
a lot of
out-of-pocket.
them won't go to see that realized access of care because that cost of deductibles and the cost of premiums are always going to be too high for them.
Now, some people are, not as many people are using care as would if there were no deductibles and co-insurance. This is true, but more people are accessing care than were before. And actually out-of-pocket costs on average have fallen. So.
Any other questions?
Yeah, so what
Yes.
would be the pros and cons of repealing Obamacare?
Well, 20 million people would lose health insurance. Probably the non-group market would fall apart. The federal deficit would go up by about $350 billion over the next 10 years. Many other provisions of the law, which have done a bunch of other good things, would be repealed. So, yeah.
And the
that-
pros?
The pros of Obamacare. Well, so as Ella was talking about in her speech, which I'm sure she'll reply to also, but there were alternatives that weren't working. So I think our burden is not necessarily to argue that we should repeal it, it's just to argue that it's failed fundamentally, not necessarily advocate for reforms, but also, so, Ella, do you wanna?
Yeah, no, so, I mean, we can entertain your questions just for like the sake of curiosity, I would say.
Well, we have a candidate who's saying that he's going to repeal Obamacare.
Sorry? Oh, well, right, sure, we do have a candidate who says he's going to repeal it, but I think the way that I look at it is, if you're, for example, like if you imagine sort of like the core of the earth, okay, or, you know, just imagine with me for a second, right, and we're sitting here, and to drill all the way down, you know, it takes a lot of layers. So the way that I see it is, if you repeal Obamacare, right, like the immediate impact, yes, would be probably a little devastating for a lot of people that were not insured, and it would probably have some economic repercussions. But it would help us peel back the layers and sort of really start understanding why healthcare costs
But how long
are
will it
really
take?
so high in the first place, right? Because the ideal system, right, is not to pass a plan, you know, to get some cool photos with your delegates, you know, and to have a legacy left behind. The point really of passing any kind of healthcare policy should be to make sure that people are insured and to make sure that they can access affordable care and that generations of their children can also access healthcare, right? That's supposed to be the plan, or the point of passing a healthcare policy. So my personal opinion, not that we would argue it here, it would be to, if you want to repeal Obamacare, it might help us tackle these employer-based coverage issues, which 50% of people, 57% of people, right, are covered by their employer's insurance. And the problem is that their employers don't have the bargaining power to negotiate like fair rates or better rates, and they don't really have an interest to, because they can simply deduct everything on their taxes. So even the Cadillac tax that I brought up, right, it still asks the employee to pay the amount that their health plan goes over the amount that the Obamacare system says. So even if you're really trying to tackle them under Obamacare, you're still making the people pay and not the employers. So it still allows employers to get away with a lot. You're still not tackling the root cause of the issue, which is soaring healthcare rates and soaring insurance rates. So yes, it would be really brutal for a while, but I mean, this is a problem that has been going on for so many years that it's really time to buckle down and solve it. So that would be my plea to Congress people.
Yeah, and is there about, I think we should just take,
to finish up.
yeah, one more question from the audience, if there, yes.
Well, both sides kind of mentioned the premium increases for next year, and there's people like the governor of Minnesota who's threatened to actually just remove his state from the marketplace altogether because he said it's unaffordable due to next year's premium increases. Would you guys say that's like a one-year market correction, or do you think that's a long-term sort of, I don't know, economic stabilizing effect of Obamacare?
So,
I'll let the proposition take it first.
so I think it's a one-year correction. The reinsurance and risk corridors went away this year, so 2 big federal government programs that were pumping money into the insurance companies just disappeared. And premiums were way underpriced for the first 2 years of the law. Actually, premiums are so low that costs are like 20% below what anyone thought. So I think there's correction to be done. If you actually look at the correlation between, the thing you worry about in insurance markets when premiums go up is that you wind up in an adverse selection spiral, that the highest risk people stay in and the lowest risk people leave. Because of the structure of the subsidies in the Affordable Care Act, that is not going to happen. There's no mechanism for that to happen. But if you look at the correlation between the rate of growth of costs and the level of costs, if there's an adverse selection subsidy, you expect that the places with the highest rates are the ones that have more high increases, that it's like a self-fulfilling prophecy. That's not at all what's happening. It's actually the places with low rates that have big increases, which suggests that there was mispricing and they're correcting it.
Is there a rebuttal?
Right, so I would argue that it's very long-term because you don't have young people buying into the insurance plans. And until you have a lot of people so that insurance companies can spread their risk, so spreading the risk means that you need to have a certain healthy percentage of the population buying into healthcare options so that the people who are sick, who need the insurance care the most, you can mitigate those costs, right? So if you have like a lot of money coming in from healthy people who aren't using that care, it can be used to treat the people who are sick. Until you have a lot of the population buying in who don't need care, you're not going to see decreased premiums. You're also not going to see decreased premiums because, as we said in our speeches, that in 5 states in this upcoming year, there will be only one option on the marketplace. That one option on the marketplace can determine whatever they want for that silver plan, for whatever they want those premiums to be, because they believe that that is what is fit for them to stay within that region. So unless they can spread their risk somehow by either getting young people or getting more competitors involved, that's not going to happen. It's going to be a very long-term problem.
Okay, and with that, we will begin our closing speeches. The first closing speech will be given by the lead opposition, Ella.
Good evening, ladies and gentlemen. So to reiterate our position, we want to explain that the burden of the opposition is not necessarily to provide an alternative system to Obamacare. It's not to advocate that we should or should not repeal the Affordable Care Act. The burden of the opposition tonight is to show that resolved, the Affordable Care Act has failed. And we believe that we have sufficiently shown that the Affordable Care Act has failed because of the structure of the system. So as we've mentioned, the reason why the Affordable Care Act has failed and cannot succeed is because the very structure of how it was implemented means when you do have 5 different states where there's a single insurer, these insurers are free to raise prices as high as they want, and there is nothing that their constituents can do about it. Indeed, we've already seen this happening in places like Alabama and Alaska, which had access to at least 7 insurers this year, but next year we'll have just 1. You've also seen that in places like New York, United Health wants to raise premiums 45.6%, and indeed they will be able to do this. The most saddening part of the Affordable Care Act, I think, is that it has created this illusion that because you can get insurance, if you can afford that insurance, you will get care. That is not necessarily true. The people that are actually purchasing this insurance are not actually getting access to care. When they do get access to care, as I mentioned, the average time that a physician has with their patients nowadays is 12 minutes. The reason why that is because of the legislative and administrative burden that the Affordable Care Act has placed on hospitals and on physicians. Physicians have less time to do actual physicianing and more time doing administrative work. And this is really problematic for what the quality of our care is. The reason why it's also problematic is because physicians are now seen as sort of tools that the patients can use to get whatever care they need. But this is not even sort of the worst part of the Affordable Care Act. The worst part of the Affordable Care Act is that out-of-pocket prescription costs have already increased double the amount, which is very problematic. We would also argue that because hospitals are merging and consolidating, they can increase prices also 20%, which is also not going to be good. I think at the end of the day, we really have to understand why the Affordable Care Act was implemented. The reason why it was implemented is because it wanted to give more people care. And I don't believe that it has done that because it sort of did not realize that states already had a significant share of risk pools where people were able to get coverage if they had pre-existing conditions. So although more people are getting coverage now, the people who are getting this coverage could have gotten this coverage if we had just fixed the state systems at the time. And I think that's the part that frustrates me the most, is that we could have done a lot more with the system that we had if we had just fixed the system rather than adapted this new system that cost so much more. And Obamacare is not simply in the process of failing, but it has already failed by all political measures. Sorry, was that time? Or?
No, you still have 30 seconds.
Oh, okay,
but,
wonderful. Yes, so I think at the end of the day, the very structure of Obamacare has failed because of the system, because of the structure of the system, and it can't be justified by the cost that we have paid for it. So at the end of the day, think about the structure of the system, the cost of the premiums, the ability of insurers to do as they wish with the patients, and think about the cost of the system versus the benefit of the actual care that we're getting.
Okay, so after 120 years, 110 years of trying, the federal government passed the Affordable Care Act in 2010. They had been trying many different efforts to do this for many years before that. They don't seem to ever have succeeded. So the opposition argues that the plan has failed on the basis of the following argument. It's like a group of people who go out for dinner and decide to go to an Italian restaurant, and then one of them, seeing the pizza, says, "But this is terrible sushi." And the other one, seeing the pizza, says, "And this is extremely crunchy soup." And the answer is, it's not sushi and it's not soup, it's pizza, and if you wanted sushi or soup, you should have looked for sushi or soup. Now, one of the arguments here is we should have dismantled the employer-sponsored health insurance system. That would have been the solution here. We should have moved to some sort of competitive system without employer-sponsored insurance. That was never on the table because people actually love getting insurance through their employers. When you ask people in surveys, it's their favorite way of getting health insurance. So it might have been the right thing from the perspective of Mark Hawley and Joe Antos, but nobody was actually going to vote for it, and it wasn't the thing that people wanted. So the Affordable Care Act is it targeted the piece of the puzzle that was not working properly. In terms of cost growth has slowed to the lowest rates in the history of recorded US healthcare cost growth. So it's true that costs have not fallen, but nobody expected costs to fall, and actually cost growth is much lower than was expected. So much so that the Medicare program, which has also benefited from the lower cost growth, is expected to last much longer than it was, and employer-sponsored insurance costs have grown at historically low rates. In terms of access, my worthy opponent keeps talking about the 200,000 people in high-risk pools, which is a lovely number, but it's a tiny number compared to the 20 million people who've gained coverage. This was not mostly about high-risk pools. Only about 10% of those people who were uninsured in 2012 before the law passed had high incomes and weren't getting coverage because of pre-existing conditions. 90% of them weren't getting coverage because they had no money. The main thing that the Affordable Care Act does is transfer money to those people so that they can buy health insurance. In terms of access to care, 75% of the people who have access to care through the exchanges and Medicaid report that they are very satisfied with their care and that they do have improved access. Out-of-pocket costs are declining. More people report having a doctor. Fewer people report that their out-of-pocket costs have put them into bankruptcy and so on. There's a lot of debate about whether we should move to a more monopsonistic system where the government can really hold down provider rates and pay them even less money than they are now. Sometimes my opponents think that would be a good idea, and other times they complain that the rates that providers are being paid are too low. Can't have it both ways. Either we lower the rates or we raise the rates, but you can't do both of them at the same time. There is this argument that the length of visits is really short. This is true, but it hasn't actually changed in 25 years, so it is not a consequence of the Affordable Care Act that visits are not as long as people would like them to be. They're just not as long as people would like them to be. They're actually longer in the United States than in any other country in the world, so that cannot be entirely a consequence of the Affordable Care Act either. Sometimes they argue that the problem is that no healthy people have signed up for the exchanges, and sometimes they argue that nobody who signed up for the exchanges is actually using any care. Either they're healthy and they're not using care, or they're not healthy and they are using care. Can't be both things at the same time. In fact, lots of healthy people have signed up for the exchanges, especially lower income people who are getting big subsidies. To the extent that people haven't signed up for the exchanges, it looks like it's actually very much on par with other programs, and the numbers are actually pretty good in terms of the total number of injured. So, on the whole, I think this law did pretty much everything that its drafters wanted it to do. It didn't do everything that everyone in the world wants it to do. I don't think that that's a reasonable standard. That's like being asked to take a physics test and being quizzed on American history. So, I'm going to stop there.
And now, before we vote, I'd like to ask you all to once again thank our debaters for being here tonight. They've worked very hard to present this material and are very happy that you were here to listen to them. So please. And now we will vote, because this is a democracy, right? Mm-hmm. So here's the resolution as it stands right now is resolved that the Affordable Care Act has not failed. And you can either vote yes, that you agree with the proposition that it has not failed, no, that it has failed, or you can abstain. So with that, and it'll be a raise of hand ballot. So if those instructions are clear, all in favor of the proposition, please raise your hand. Okay, all in favor of the opposition? Okay, all those abstaining? Okay. With a 18 to 2 to 5 split, the resolution passes. Thank you all for being here tonight. We have a colloquium on November 16th on global cities, urban protests. Please come. If you want to sign, we ask you all to sign out as you leave. You'll have a computer. Please check out. If you want to debate, please come talk to me. Thank you all. Have a good night.